I feel very, very humbled to be here. I remember coming to this conference maybe about 10 years ago, looking at presenters like Louise Kuhn, and I was like, wow. I still feel that way, so thank you for this opportunity. So I will be talking about updates on PMTCT from Malawi, the country where Option B Plus started. I'll start by providing a very brief summary on the history of Malawi's B Plus program. Then I will review how Malawi's PMTCT program is going, both the successes and the challenges. Next, I'll provide some highlights on why Malawi has been successful, not only in scaling up and sustaining B+, but also how it continues to be successful in further optimizing PMTCT beyond B+. Okay. So Option B+, the intervention to provide universal lifelong treatment for all pregnant and lactating women, originated in Malawi. Option B Plus was started because of some theorized benefits: effective reduction of vertical transmission, benefits to maternal health, reduced partner transmission, that it would be effective, cost-effective, and it really simplified delivery of PMTCT care. It was initiated in July 2011 and resulted in a dramatic and immediate increase in PMTCT uptake. By 2014, over 20 countries had endorsed Option B Plus for their national PMTCT programs. Oops, sorry, wrong way. Okay. So how are things going? Has B Plus lived up to our expectations? Malawi's PMTCT coverage amongst pregnant women living with HIV benefited from Option B Plus in 2011 and continues to be excellent. It's estimated to be greater than 80%. Malawi's ART coverage amongst pregnant women living with HIV also greatly benefited from the initiation of Option B Plus in 2011 and is still very good. It's also estimated to be greater than 80%. And as estimated by Spectrum, vertical transmission has declined. Ooh, sorry, it's going too fast. Moreover, infants who make it into the early infant diagnosis system appear to be starting ART. So B Plus has been very successful. However, new challenges have emerged. There are more women already on ART when becoming pregnant. Recent data indicate more than half of pregnant women living with HIV are already on ART when presenting for antenatal care. And important questions emerge. Are these treatment-experienced women virally suppressed? Do they have resistant virus? We don't know. In addition, there is a rising need to ensure adequate support for contraception and family planning, which is currently unmet. Vertical transmission. It has decreased, but there are gaps. Transmission, as measured from the MOH early infant diagnosis data, is low, less than 3%. However, Spectrum estimates are that vertical transmission is 6.9%. This is likely because it includes transmission for women who do not receive any prophylaxis and those who drop out. So there is still room for improvement. Early infant diagnosis testing is improving, but also could be further optimized. This is the number of infants registered in the EID program. Sorry. And this is the proportion tested. Following an initiative started by the Ministry of Health in 2015-2016, which I will get to, coverage has improved. However, it could be further optimized. Currently, we are averaging about 75%. And then, of course, is maternal retention in ART care. As mentioned, maternal ART coverage is very good, and it's quite an achievement. However, retention appears to be suboptimal. Recent data shows 6-month retention is approximately 82%, and 36-month retention is 64%. There are several retention optimization initiatives ongoing in Malawi, and the data does seem to suggest retention may be incrementally improving. Several studies from Malawi have tried to tease out what is happening with retention. One factor that appears to be associated with retention is the health facility you are from. This is an analysis of 12-month retention data from one district in Malawi, and as you can see, there is great variability in retention by site. So what are the secrets to Malawi's success? I cannot overemphasize the importance of political will and strong leadership from the Department of HIV and AIDS. They have done an outstanding job thoughtfully making decisions that are right for Malawi, of which B+ is an excellent example. In addition, Malawi has also benefited from generous funding support, including from PEPFAR and Global Fund, and has a broad base of active stakeholders, including people living with HIV and implementing partners. Malawi has a robust data system to monitor progress, as well as quarterly supervisions, all of which was well in place prior to B+, tightly monitored supply chains, and integration of PMTCT, ART, and antenatal care. And a key contributing factor has been Malawi's experience with and innovation around task shifting. So Malawi's history of successful task shifting, or enabling non-doctor cadres to initiate ART, really helped to launch Option B+ in Malawi. And Malawi's leadership in task shifting continues to help move Malawi beyond B+ and address ongoing gaps in PMTCT and MCH care. An example, to help improve HIV diagnostic testing coverage and reach the first 90, in 2015, Malawi initiated the HIV Diagnostic Assistant Program, introducing a brand new cadre of health worker who was focused primarily on HIV diagnostic testing, including HIV testing and counseling, syphilis testing, and early infant diagnosis and viral load testing. This was a national scale-up. We reviewed data from 457 HDA sites, pre-HDA deployment and post-HDA deployment. We compared several measures, including HIV testing, syphilis testing at ANC, and early infant diagnosis testing. And we evaluated the changes in the slope and level of these testing measures through single group interrupted time series analysis. Okay, so what was the impact? There was an improvement in the number of persons receiving HIV testing. The trend and level of this change before and after HDA deployment was statistically significant. In terms of PMTCT-related outcomes, there was improvement in both the number of infants receiving early infant diagnosis, as well as pregnant women receiving syphilis testing. The trend and level of these changes was significant. And the proportion of positive syphilis test results is now very close to the syphilis prevalence estimated from the 2010 ANC Sentinel surveillance round. What next? Malawi is working to further optimize maternal retention and EID testing coverage via the use of peer supporters, community health workers, new guidelines for community PMTCT, as well as point-of-care EID testing expansion. Malawi will need to support the increasing numbers of pregnant women who are already treatment experienced. And as noted, there are other gaps which Malawi has started to work on. Women who don't receive prophylaxis, new infections amongst women during pregnancy and postpartum, as well as addressing other maternal health concerns, such as mental health. Before I go, just a quick note about what we are doing about dolutegravir. The recent challenge with DTG has already been discussed at this workshop. And in brief, Malawi, for now, will continue the fixed-dose combination tenofovir, lamivudine, efavirenz, and this will remain standard first line for women who may get pregnant while on ART until additional evidence on safety is available. In conclusion, Malawi created and successfully scaled up B+, a highly effective PMTCT program. Malawi has sustained B+ successes with excellent PMTCT and maternal ART coverage, efforts to retain women and infants, and decreasing vertical transmission, moving close to elimination. Malawi has also moved beyond B+, innovating and addressing other gaps in PMTCT, such as syphilis and EID testing coverage, with interventions such as its HDA program. And Malawi seeks to continue to improve and grow, and much work remains. Thank you very much. It was a pleasure.